Low sex drive and hair loss have recently been added to the list of symptoms experienced by those with long COVID. But neurological disorders are emerging in as much as one-third of long COVID cases, and that can range from brain fog to being simply unable to get out of bed. Now, we're joined by Jack Lambert, Professor of Infectious Diseases at the UCD School of Medicine, who recently appeared before the Oireachtas Health Committee to talk about the issue because he's been doing some research in this matter. Jack, good morning and welcome.
Yeah, good morning.
You've gone through quite a number of patients with long COVID. Just in general, what are your conclusions?
Well, my conclusions is we started seeing patients back in April 2020 with long COVID, and the data coming out of China said they were 6 months ahead of us. A certain percentage of patients don't recover. So we were able to get a HRB, an Irish grant to study, but we've also, besides studying 150 patients intensively, we've managed almost 1,000 patients, and some patients 2.5 years down the way, as I say 29 months now, are just not over the COVID infection that they got, 2.5 years before, and it's primarily the brain that's been affected, not the heart and the lungs, it's the brain. And like I said, we need to kind of really get additional resources to support these patients because currently they are not being supported in Ireland to manage that condition.
Now, we mentioned brain fog, which was the term coined initially, where people just couldn't seem to concentrate and couldn't do the things mentally that they were used to doing quite routinely. What, in addition to that brain fog, what other neurological conditions are you observing?
Right. Well, patients who didn't have headaches before are having these uncontrolled headaches, head pressures. People are having, funny things going on with their ears, ringing in the ears, tinnitus, problems with the eyes, the cranial nerves that come out of the brain. The people with long COVID sometimes have smell and taste loss. But it's also all the other nerves that control, temperature regulation, blood pressure, pulse. So all of the cranial nerves seem to be involved. So it really is a condition that affects the brain, and then it also affects patients' moods, because, like I said, if you've got inflammation in your brain, it's almost acting like a viral meningitis. You get photophobia, headaches, concentration problems, brain fog, sleep disturbances, mood changes, personality changes. We see that in patients who have had closed head trauma. You're in a car accident or something like that. So they have a whole range of neurological problems, all caused by COVID, that just haven't, some of them are still with these symptoms 29 months later.
Now, what is the science, rather than, if you like, the observational evidence from these patients? Is there any science? Because I remember Luke O'Neill telling us that, they have found bits of COVID lurking around the body, and that might explain some of the long COVID symptoms.
Well, there is a debate that there's still virus hiding in the body, but I think this is not new. Patients get an infection, the infection dies off, and then the damage to the brain, the damage to the organs of the body persists, and then the immune system starts attacking. So, but there is evidence when they've done brain scans on a population of patients with long COVID, not just PET scans. There's areas the brain that I was telling you about, the posterior parts of the brain that control, pain control, respiratory center, that controls your heart rate, coming out of the vagus nerve. So there's objective evidence on brain research studies that have looked at PET scans that there is persistent inflammation there in these patients.
I was reading a report in one of the newspapers today suggesting there are three broad categories of long COVID: those with the neurological symptoms you're talking about. The second group would be those with the respiratory symptoms, and the final group would be those with a diverse range of symptoms like muscle ache and pain, changes in skin and hair. The researchers said these three subtypes were evident in all the variants, whether it's Delta or Omicron or any variation on Omicron. Is this just a handy categorization, or are there different methodologies at work in each of these types of groups of patients?
Well, I think it's a handy categorization because, we're supposed to be providing support for patients in Ireland. And right now, the national plan is really focusing on pulmonary, the respiratory complications. Huge amount of money has been put into millions into hiring staff to support the post-acute pulmonary complications. That was a Delta issue. Most of the pulmonary complications don't exist anymore. The new variants all give the second and third category, the brain issues and some of the other, diverse issues, the immunological issues that exist. And we haven't put almost any resources in Ireland into, dealing with those issues. So it's a useful categorization. I would say 90% of people have, brain issues. Less than 5% have pulmonary issues, but I would say about 70% of the resources in Ireland have been given to manage the pulmonary complications that almost don't exist anymore.
Okay, so the pulmonary conditions tend to resolve far more quickly than these neurological conditions. Now, what about treatments, Jack? Because one of the treatments for COVID itself is Paxlovid, and we know, because we looked at Joe Biden, he suffered what they called a rebound, because there was some evidence that a small number of people taking Paxlovid, as soon as they stop taking it, the virus shows up again, and Joe Biden seems to be one of those. But does Paxlovid, for example, work if the virus is hidden away around the body? Would Paxlovid mitigate some of the long COVID symptoms?
I don't think that's the strategy we should be choosing. As a rule, people think that, coronavirus dies out. This is a post-infectious process. So we should be really looking at, rather than antivirals to kill off a virus that's already died off, I think it's rare that there's going to be persistent virus in patients, although there are case reports of that happening. I think the focus really has to be on neuro rehabilitation. We have done a study at the Mater, just a pilot study, using a product called low-dose naltrexone, and it appears to have benefit in helping people with long COVID. We need to start looking at interventions that are focused on the brain, not focused on the virus. And there's a number of studies going on, and we should be doing those same studies in Ireland and supporting the patients. Currently, patients are just being tested, left and right, being brought back every 3 months, no interventions being given, and that's difficult to watch these patients.
And Jack, what would the neurological interventions be? Would they be drug therapies? Is that the way to do it, or do you have to retrain the brain?
Well, it's both. There are some drug therapies focused on the brain, and I mentioned one of them, low-dose naltrexone, but part of it is also reprogramming the brain, absolutely. There's a whole area of science called neurophysiology, neuro rehabilitation. The patients at Dunleary, the National Rehab Centre, they manage patients with closed head injury. They retrain the brain. I think we need to put a lot more resources into neuro rehab because the long COVID patients are acting like closed head injuries, and there are protocols already established. We need to adapt what we've learned from neuro rehab with closed head injuries and other infections to manage long COVID.
Some of the comments and questions coming in. Is your guest aware of the rising cases of sciatica from COVID?
Well, yeah, exactly. It affects the nerves coming out of the brain. It affects the sympathetic, parasympathetic nervous system. So yes, we're seeing all these complications. We've been seeing these complications since March 2020. So this is not new. It just hasn't been incorporated into the Irish long COVID plan, and we need to urgently redirect some of the money that's been put into current resources or find new resources to support the neurological, neuropsychiatric complications of long COVID.
This one again. A neurological impact. I have tinnitus, having had COVID in March of this year. Is this permanent or will it burn out?
Well, I don't think it's just going to go away spontaneously. I think, like I said, there are ways to treat this, and at the present time, we're not doing anything to support these patients with neurological complications, but I think it is fixable.
Now, there is a lot of talk about the current surge or wave, plateauing and perhaps diminishing, but Jonathan says, if all of these issues as a result of contracting COVID, why on earth are we not having mandatory mask wearing?
Right, and I still wear a mask. just because I don't want to lose time at work and I don't want to catch long COVID myself. So I do think that we have to, people are going to be reinfected. People can catch up to 3 COVID infections in a year despite being vaccinated or even despite being naturally infected. So I think people either say, I'm going to take my chances, not wear a mask, or we continue to be careful wearing masks. And I think we should encourage people to do this in public situations. It's not the same as it was, 2 years ago, but the virus hasn't gone away. We need to find ways to mitigate transmission.
In dangerous or potentially dangerous situations, that's the thing to do. A couple of things on viruses generally. Haven't there always been neurological effects to various viruses? Another one is in Lyme disease, a post-viral neurological disorder. And of course, ME, people who often were not believed that they had this thing, myalgic encephalomyelitis, they can be ill for years trying to recover from the virus.
Well, so first off, Lyme is a bacteria, not a virus. So antibacterials, antibiotics take care of Lyme. But also patients need all the additional. Lyme affects the brain the same way. So people need the same with chronic Lyme, need the same neuro rehabilitation. But going back to this whole issue of ME, chronic fatigue syndrome, what triggers that? It may very often be an occult infection that triggers these conditions. So I think, long COVID and all the complications, which are similar to patients with chronic Lyme, patients with, chronic conditions like ME, there's probably a common factor there. So I think maybe the science will benefit patients with chronic Lyme and ME, the science that's coming out of long COVID, I'm hoping.
Finally, Jack, what reaction did you get in the Oireachtas committee to the news that you brought them about long COVID and what a challenge it is going to be, whether they acknowledge it yet or not, a challenge it's going to be to the HSE?
Well, I've actually asked for meetings with the HSE and asked to present the data that we've put together, and actually offered to support them in rewriting the guidelines so that they would help the long COVID patients. But I haven't got any feedback yet. But my hope is by getting this out into the public domain, that the HSE claims to be lean and agile and willing to change based on new findings. Well, we have new findings, and we don't have a current strategy to deal with the patients, based on those new findings. And these findings actually are a year and a half old. They're not actually that new. So I think we need to, the hope is that the Oireachtas, session, which I was reluctant to go to because kind of put your neck, your head on the neck. I'm hoping out of that will come something that will benefit the long COVID patients, and the HSE will get behind, the new science.
And a huge number of them are people who work in the HSE on the front line.
There are, and I manage those patients. I see lots of healthcare workers and others who are still devastated 2 years later. We need to do more.
Jack Lambert, Professor of Infectious Diseases at the UCD School of Medicine, thank you very much for joining us.